I'm Rosemary from Melbourne. Haven't had time to type that in the chat. And so it's Boonwurrung country. And yeah, we really appreciate you guys actually giving us this opportunity to talk tonight as fellow patients, because we completely understand what it's like to live with these conditions. And even though they're different conditions, we're here tonight to talk about, we'll do a comparison, but there's actually a fair bit in common as well. So to start off tonight, I should say we're not professionals, we're not health professionals, you guys know that. And I'm certainly not a professional presenter. So if I talk too much or whatever, just type in the chat to slow down. But we've done a bit of a summary about what we're talking about tonight. So we've got a game to start with. Then I'll do a quick summary about the two conditions, the similarities, who gets them, and so on. We'll talk about the symptoms of each condition, how they're diagnosed, the different treatment options. We'll do a quick summary if we have time. We'll watch that. We've got some resources that we'd like to share with you. But all of that is actually that's the facts and figures part. We want to get through that relatively quickly because it's the next parts that we want to talk about is our stories. So we'll share a little bit about what it's like to live with RA, and we'd love to hear your stories about living with lupus. So when we get to that point, you can either type it in the chat or hopefully we'll have time to actually have a live chat with you and merge into the Q&A after that. So we'll play that by ear, but we'd love to hear from as many of you as we can. And feel free, if you have questions in the meantime, definitely Michelle and Naomi will be monitoring in the chat. So now for just a little bit of fun. Okay, here we've got a whole range of factors which could be associated with RA or lupus. So just have a look at the list at the screen and decide which ones you think apply to you and to tally them up a little bit in your head. And while you're doing that, think about which ones do you think, oh, that's just RA or that one's just lupus, to see if they might apply more for one than the other one. So it's just for you to think about, but just give you a few more seconds. You've probably tallied that up by now. So the actual fact, the answer to all of that is they are all symptoms of both. So with lupus, you probably know you can have swollen joints. With RA, you get brain fog. Pain is, well, we all know pain and fatigue. We know that. We deal with immunosuppressants. We get other conditions, other organ involvement. So that can happen with RA as well. Depression and anxiety, unfortunately, go hand in hand with having chronic conditions. Particularly when you've had troubles getting diagnosis and people just don't understand what you're going through. So for us, it's like if, say, you've got rheumatoid arthritis and people say, oh, my nan had that. So no, she had osteoarthritis. Different thing, still painful, but not the same thing, and certainly not a systemic condition. So I was going to ask something then, and I just completely lost it, so I'm just going to wing it. Okay, that's all right. You can go on to the next one. So we've put a lot of these on the screen. We'll just run through them, and some of them may be familiar to you, but some of them won't. So these are just the facts that are common that apply to both conditions. We know they're both autoimmune diseases, or I presume you know that we don't know what causes them, but we know it can be things like genetics, hormones, stress, environmental factors, or other infections can trigger it as well. And sometimes we just don't know. It just starts out. And the great fun about having these conditions is that it makes us more likely to have other ones. So you can actually have both RA and lupus. That is quite possible. You can throw in Sjogren's disease, you can throw in inflammatory bowel disease, Graves' disease, which is a thyroid condition, psoriasis on the skin or psoriatic arthritis, and ankylosing spondylitis, which is an autoimmune arthritis that affects the spine and the pelvic area, and others as well, other parts of the body. And both conditions can affect the entire body. But there are slight differences, they're significant. So with RA, you mainly associate it with the joints, and a lot of people don't realise you can actually have organ involvement as well. So eye conditions, you can have inflammation in the lungs and so on. And lupus works the other way around, so it mainly affects the organs, but for some people it can affect the joints as part of the whole systemic experience that we have. So I'm just reading here from Faye until Dragonclaw. I had no idea that RA even had an organ involvement. To be honest, neither did I when I first got it. That became a something that I became aware of after. It was like, oh, great, I've got that to look forward to as well. But as with all of the things, we don't all have the same symptoms. Another great similarity, I don't know if it's great or not, but it's a similarity, which I actually didn't realise for both conditions, is when you do have the arthritis symptoms, is that the textbook case that our doctors are taught is it starts with the small joints and progresses into the bigger joints. But in reality, any joint can be affected in any order. And if you happen to have your shoulders or your hips affected first, it can really muck up your diagnosis, just because it makes it a bit harder. Excuse me. I forgot to remove that duplication, so that's just the same point there. And yeah, the symptoms of both can vary from person to person. For example, Naomi and I both have RA, but we don't have the same symptoms. And you probably all find that with lupus as well, given that there's such a variety of symptoms that you're not all going to have the same mix. Both of them can vary from mild to severe. So not everybody gets severe. Luckily, some people just get mild conditions. And they can also come and go, and they can vary in intensity. So sometimes they come and go over years, sometimes they come and go over hours. Certainly for me in the past, sometimes my RA has flared up a bit in the morning and completely gone by the afternoon.
Rosemary, I was going to suggest that we just show the difference with a quick example of our hands.
Oh, good idea. Yes.
In both of us having RA, and that Rosemary's hands haven't really been affected at all, whereas mine, well, it might be hard to see on the screen.
Do you want to stop sharing screen for a sec?
I can't make a fist or anything like that. So, yeah, so that's, one very obvious difference in both of us having RA.
Yeah, definitely. We'll cover that a little bit more in our stories, but it is great to show you that difference about how it can vary. Both can be diagnosed at any age. People presume that arthritis is an old person's condition, and that is an absolute myth. Again, as Naomi will touch on in her story, that she started it as a teenager. We know people that have had it from being a toddler. And I'm sure you all know that neither of them has a cure at this stage, but we can manage them. We learn to live with them, and it's not a death sentence. It's not the end of the world. We can manage okay, providing we get the help we need. There are different types of arthritis to start with. So there are actually over 100 different forms of arthritis, and a lot of people don't realise that. So the arthritis that comes with lupus is one. Osteoarthritis is the most common. Rheumatoid is the second most common. Then there's psoriatic arthritis, ankylosing spondylitis, gout, a whole range of others. But for rheumatoid arthritis, there are actually some subtypes as well. So there are different biomarkers or blood tests that you can do, which we'll touch on in a moment. But if your blood tests show that you've got the biomarkers for RA, they call you seropositive RA. So it's a reasonably definitive diagnosis, whereas you can still have all the clinical presentations, but you don't have the biomarkers in your blood. So that's called seronegative arthritis. And we mentioned kids having arthritis. So it used to be called juvenile RA. These days it's broadened to juvenile idiopathic arthritis because it can develop into other forms of arthritis, of autoimmune arthritis as well. then I believe most of you would know the subtypes of lupus, and you really have to excuse my pronunciations here because I don't normally say it. So the systemic lupus erythematosus, I'm hoping that's right, or SLE, it can affect almost any organ or system in the body, but most people will mainly just get it in the skin and joints. Discoid lupus or chronic cutaneous lupus erythematosus, generally milder, but not always. And most people with that strain only get the skin symptoms. Subacute subcutaneous lupus. Took me a while to practice that this afternoon. The main symptoms are skin rashes, sun sensitivity, and joint aches, and drug-induced lupus. So some of you may not know that you can actually develop lupus from your medications as a side effect. So it can be a reaction, but the good news to that is that if you stop taking the medications, the lupus generally clears up. Then as for who gets RA, it's just over 500,000 estimated Australians. It's estimated to have RA in 2022. Generally, it affects slightly more females than males. It used to be thought that it was mostly females, but now they realise a lot of guys do actually get it. And the onset of symptoms, again, it's not an old person's disease. It generally develops in middle age, 35 to 64, but it can occur at any age. Whereas with lupus, about 20,000 Australians are believed to have it. It's mostly women. I believe it's about 90%, but you guys can correct me on that. And it's generally detected in people from 15 to 45. So just a slight difference there. And you may already know that it's more prevalent in Indigenous Australians as well. So thank you. You just flip over to the next one, the next slide. Thank you. So in terms of symptoms, we've covered some of them already. Fatigue, flu-like symptoms, achy muscles. A lot of those are because your immune system is fighting so hard that it takes all your energy, and it's bringing on all these things as though your body's got an infection in it, which it doesn't. Loss of appetite, brain fog, which again, your immune system's using all your energy and doesn't leave very much left for your brain to think about things. But chronic pain can distract you, lack of sleep, that can all contribute as well. Joint pain, swelling, and redness are fairly obvious. And the morning stiffness lasting over an hour, including sitting for a while, is another telltale sign. So where they differ is with RA, you can develop nodules or swollen bumps under your skin, generally around the joints, but you can get nodules in your organs as well, like your lungs. They're not bony. It's more like a hardened tissue, I believe, and they can become permanent, but in most cases they're temporary. And also inflammation from RA can actually damage your joints and erode them, causing you joint damage over time and potentially fusing the joints as well. Whereas with lupus, there's a much broader range of symptoms. Rashes are very uncommon with RA, so they are very common with lupus, especially the butterfly rashes on your face or the ones that when you react to sunlight. There's often lung involvement with lupus, so the chest pain and the shortness of breath. Frequent bleeding or bruising, I believe that's related to circulation issues. Neuropathy-like symptoms, so the tingling of the nerves, so that can all be part of it. Oral and nasal ulcers, kidney involvement, it's an unfortunate one that can have big issues. Hair loss. Now with the arthritis in lupus, it's the bone erosion generally doesn't occur, but the tendons around the joints or the ligaments can become lax, so it can cause problems with the joint movement. So that's my understanding of the differences there. So over to the next one, please, Naomi. So in terms of diagnosis, there's some similarities. So in many cases, the conditions have been active or set in motion well before you get the symptoms. So it's important to get your diagnosis as soon as possible. but neither of them actually have a specific test. So that's what makes it so fun for us. And even to throw it into the mix, your blood tests don't always match what's happening in terms of your disease activity. And negative blood tests don't automatically rule out that you've got the condition either. So what will happen with GPs with the diagnosis, if they're switched on and understand what they're looking at, is they will generally conduct the clinical examinations, and the blood test will hopefully support what they think their diagnosis is, and then they will refer on to a patients onto rheumatologists. In very rare cases, the GPs can actually diagnose if they're confident enough to say that they're very, very sure of what it is. Differences in terms of diagnosis are the blood tests. So with RA, there are two main blood tests that are used. With both of them, I should mention there's inflammatory markers as well, which do indicate some sort of issue with the immune system. But the specific ones for us are rheumatoid factor, so that's a protein in the blood that attacks healthy tissue. If you've got really high levels of it, you test positive for that, there's a good chance that you've got RA, but some people who are positive don't necessarily have RA, and vice versa. As I mentioned, you can have the seronegative arthritis as well. And the other one is anti-CCP, or anti-cyclic citrullinated peptide proteins. That's another marker in there which may indicate RA, but it's not definitive. With lupus, the main blood test is the anti-nuclear antibody test, so that detects the presence of antibodies that specifically attack the body's healthy tissue. A positive A&E test does not necessarily mean that you've got lupus again. And the other factor that doctors use in their clinical scoring systems for both, so they use clinical scoring systems for both conditions. So the scoring systems are different. For us, it's joint counts usually and functional activity, and they take you through these questionnaires and work through a measure of what your disease activity is. So together with your blood test and their other observations, that's what they can throw in together to help them come up with a diagnosis for you. Okay, treatments. Treatments are actually pretty familiar to you guys as well. The pathways are almost identical. Painkillers, it's a no-brainer. Anti-inflammatory drugs or NSAIDs like aspirin, naproxen, COX-2 inhibitors like Celebrex and Mobic. So they help with a lot of the symptoms, the fever, the joint pain. Some people use anti-malaria drugs like hydroxychloroquine. So that is specifically either for people that can't use methotrexate, or they might be to treat milder conditions, or specific ones like skin rashes come into it a bit more as well. Corticosteroids or steroids like prednisolone are very common, very effectively used as an anti-inflammatory, and although they don't understand why it does affect pain as well. But as many of you probably don't know, it's not ideal to be on them for a long period of time because there are side effects for those as well, particularly if you're on high dose. But some of us don't have a choice. And so for me, it's part of my mix all the time anyway. But then there's the disease-modifying anti-rheumatic drugs, or DMARDs, which actually suppress the whole immune system. And this is the point where we're actually starting to work on what helps or slows down the disease progression. So it doesn't cure it, but it slows it down. So drugs that fall into this category are methotrexate. We have a Rava, is one of ours as well, and I'm sure you guys have a mix of quite a few. And then as part of that family of medications, you get the biologics. So they're actually grown from live cells, and they are either injected or infused into the body. So many of us, for example, use self-injections subcutaneously, so just into our nice handy lot of tummy fat, which is there specifically for that purpose, or mine is, I reckon. And so they actually target specific parts of the immune system, and they're approved for those with moderate to severe disease activity, providing you meet the approvals. But with treatments, here's where there are some more differences. RA's had biologics available in Australia for over 25 years. And so by now we've actually got quite a few of them for us to try that work slightly differently, that target different parts of the immune system. So, for example, there's adalimumab. Some of you might be familiar with these names, but I'll say the brand names as well. So adalimumab's the most common brand name is Humira. Tocilizumab is Actemra. Rituximab is Mabthera. That's an infusion. And infliximab or Inflectra is also an infusion as well that you go into an infusion centre for. Now, we actually have another type of DMARD that is targeted, but it's not made from live cells. It's still synthetic, but it's an oral medication and it actually has similar effects to biologics in terms of how it works and also in the approval process. So for us, sometimes the biologics might work better for some people. Sometimes the JAK inhibitors might. They've only been on the scene for about 6 or 7 years, I think. So, but we get the options. We get to experiment a little bit, but we do have limitations on how many we're allowed to have on the PBS. That's a whole different story. Now for lupus, you guys are most likely well aware that you now have your biologic. Oh, so I'll go read the question. I did have that in my original slide. JAK stands for Janus kinase inhibitor. So that's targeting, so the Janus kinase, I think they're proteins. It's another part of the immune system. So that's what they work on. Rather than biologics tend to work on T cells, B cells, and a few others as well, but they're the main ones for us. So for you guys, yes, the Safnillo or anifrolumab, I haven't got used to saying that one yet, thankfully was approved for the PBS, and I'm hoping it makes a huge difference for many of you because we know the difference biologics can make. We really want that for your community as well. And I believe you guys have cytotoxic drugs like cyclophosphamide, which is a different form of immunosuppressive agent, which may be more likely to be used for those with kidney inflammation and so on. But if I've got any of that wrong, please correct me because I'm learning as well. But hopefully that just sort of gives you an overview of that. So summary of similarities. This is pretty easy. I'm just checking the time here as well. Symptoms can be really confusing, and when you get one come up, you say, what on earth is this? Is it my current condition? Is it something new? Is it just something that'll blow away next week? So we get that. We understand the brain fog and the fatigue and all the drains on your whole system. We understand the frustration of dealing with health professionals and the joy when you actually find one who listens and gets it and helps you. I should have flipped these points around because delays to diagnosis is a big problem for many of us because I'm not sure about lupus, but I know with RA there's a window of time from when your symptoms first start. And in some cases it's only a few months, where if you start taking methotrexate or other DMARDs, you've got a pretty good chance of actually controlling the disease a lot more, whereas the longer you wait, the more likely you are to have joint damage and other manifestations as well, because the disease has already progressed a fair bit. So that's why we want early diagnosis. Excuse me. We've mentioned that we've got quite a few comorbidities in common, like Sjogren's disease and Raynaud's that was mentioned before as well. And we need to be aware that because we've got these conditions, we could get other ones, but not to be scared by that thought, because people, particularly newly diagnosed people, may think that they are automatically in for that ride. And we have to reassure them that no, it doesn't mean you're going to, but just be aware of it so that if you start to get some weird symptoms that you go to your doctor straight away and talk about it. And then this could have been a whole other topic on its own. The joys of actually living with a chronic condition, like how on earth do you manage working? How do you, when you're in pain and you're tired and your brain's not working? or studying? How do you pay for it all? How do you deal with the variable symptoms? And so you just can't even plan ahead, or the fact that they're invisible illnesses mostly. To the trained eye, they're not, but the other people may not believe you, or may think you're faking it, or they're not as severe. So, yeah, definitely similarities with both of those there. So if we go on to the next slide, Naomi, I might give my voice a break a little bit if you wouldn't mind just talking about the resources that we've got. Is that okay?
Yeah, for sure.
Okay.
Yeah, we thought we'd just share a few resources on that we have on our website. So one of the things we all know is that we need support with chronic conditions, and we found in our community we were getting quite a lot of questions of what am I eligible for, and I think there's still a lot of maybe confusion and gaps there about people's knowledge about what they can access from the government if they need to. So we put a web page together which has all of those in one spot, so you don't have to really trawl the government websites to find them. So it's all there, and it's actually our most popular page on our website. So it shows you how how important extra support is. And the other one is the health and community services for people with chronic conditions. So things like physiotherapy, dietitians, allied health, and counselling and support groups. So that's another list of we've sort of put together into an easy sort of way. We actually are going to redesign it so it's even easier to trawl through, because it's actually grown quite a bit over the years. So we're going to make that a little easier to navigate. We've got quite a few pages on our education section of our site, but one of the more recent ones we've put up there is about family planning and pregnancy. So it has lots of resources on working your way through, from planning pregnancy, so for women and men, and also through pregnancy and then parenting. So there's a couple of patient stories sort of linked to that as well. So we hope that's beneficial to a lot of people living with autoimmune conditions and chronic conditions. And the other one is our podcast, our Patient Prep Room podcast, which I host, and we're growing that a lot more this year again. So we've got some episodes coming up on ankylosing spondylitis and psoriasis. So we did a psoriatic arthritis series last year, and so we've got 2 more, and we're hoping to do one on lupus at some point. So to add to that, so there are, I guess, just a sprinkle of some of our resources that we've got on our Creaky Joints website. So yeah, that's that. So I encourage you to visit to creakyjoints.org.au. So in short, I have RA, so I'm 55. No, hang on, 54. Just about to turn 55. I was diagnosed at age 12 with juvenile rheumatoid arthritis, but I'd had many symptoms for a number of years previous to that, and the doctors said I had growing pains, I had sore feet, sore knees, I was tired, I was an extremely active child, very double jointed, very, just active all the time, and this just sort of like slowed me right down, and it was just peculiar as to what was going on with my body, because it would come and go. So on holidays I'd have sore feet and they would sort of swell up a little bit, and it's like, oh well, we'll buy you new shoes, and no, it's just growing pains, it's okay. So this went on and on and on, and then one day I just basically couldn't get out of bed. I just couldn't stand up. So went to hospital, spent a week in there being poked and prodded, and walked away with lots of aspirin in 1982, and iron tablets and all sorts of things like that were really delightful to take as a 12-year-old. and had the diagnosis of that. And it's like, oh right, well, so what is this thing? And no internet or anything like that to Google what to do. And so it was that journey of high school and navigating that with a lot of pain, and which seemed to get worse and worse as the years went on, and not a lot of treatment options then. Fortunately, unfortunately, I have quite a sort of an aggressive form of rheumatoid. So I have over the years had my both knees and my both hips replaced twice, and a shoulder replacement. So my first set of replacements was in my 20s, which was extremely young. And that was purely from a pain and function point of view. I was not being able to function very well at all in life. So I had those done. 15 years later, they wore out. I had to have another set. They are still in me. I haven't had any more, thank God. But over the years, I've unfortunately had a number of infections in the joint, and I still live with a chronic knee infection, which I've had for 6 years. And that's just an annoying thing that you can get with. So that's something that a lot of people are probably unaware about with prostheses is the risk of infection. So it is there. And because of our immune system issues and things like that, there's that higher risk of getting infections. So, other than that, I manage life as well as I can. I moved to a remote island in Tasmania because I could, against all my doctor's advice. They'd said, you're absolutely mad going to an island with a tiny little hospital and one GP. And I said, I don't care. I'm going to live the life I want to live. And I think I struggle with some things, but I think my life is so lovely here that it's worth it's worth having to jump on a plane to go and see a doctor, even a specialist. And I guess I've been on the same biologic for about maybe 15 years now, abatacept. And I went on that as a trial, and that's one my rheumatologist is happy to keep me on because it has a low, even though I got an infection, has a low infection profile. So he doesn't want to change me on that, and I'm managing pretty well. My rheumatoid is pretty good considering things. So I'm waiting for the next best thing though, because I still think that there's, I'd like to feel even better than I do. So I'm sure we're all in that boat too, that we want to find the next best thing. So that's pretty much me. If anyone has any questions after, you're welcome to ask.
Thanks, Naomi. So the interesting thing with us, if we compared our hands, we're actually the same age as well. But I didn't get diagnosed till I was 37. I wasn't very active as such, but I was still pretty healthy. But my hands just started to hurt. But the weird thing is, first it was one hand, and it was just the thumb on one hand, and then it stopped, and then it was a finger on another hand. And I just kept, because originally I just said, oh, okay, I've sprained my thumb. And I just iced it a bit. But when it just kept flicking around and I just couldn't work it out, there was always something hurting, but it wasn't the same spot. I just walked into my GP, held up both hands, not realizing that was another similarity, that they're symmetrical. RA is a fairly standard sign. So I just said, my hands hurt. And so we had a close, and by that stage, one of my feet, my toes had started to hurt as well, but I hadn't made that connection. And then the other one started afterwards. And I was so grateful that I had a GP that was switched on, knew what RA looked like, knew the classic signs of it, and sent me straight off for blood tests that we spoke about earlier. And mine came back positive. So I had a diagnosis within about 3 months of getting symptoms, which is very rare. Unfortunately, that GP retired soon afterwards, but he set me on the right track. So I started on methotrexate, anti-inflammatories and so on, and I'm still on them to this day, and prednisolone. But I decided to have a little bit of fun and throw in some other symptoms along the way. So that was 2007. By 2013, I added in fibromyalgia. For me, thankfully, that's relatively mild. A quick way of describing that for those who don't know is your sensory system goes into overdrive. And so your body thinks that, say, for some people, the sense of touch, that the mildest touch is really painful. For me, it's more bright lights sometimes. I can get sensitive to loud noises, and it can also amplify your sense of pain. But that's great. Thankfully for me, it's not as severe as for other people. I threw in type 2 diabetes from cortisone, cataracts from cortisone, and thankfully been dealing with both of those, and they're okay. Then next up was ankylosing spondylitis in 2017, and that's apparently, supposedly rare for people with RA to get AS as well, but I could name 5 people that I know off the top of my head just through support groups that have got both. So I think it's actually more common than people realise. So for me, that affects the sacroiliac joints, which are the joints that join the spine to the pelvis, but I don't have it in the spine itself. So I'm grateful for that. But at the point where I was on RA, I was on a biologic, the same one that Naomi is now on, abatacept or Orencia, and I'd been on that quite comfortably for years for my RA, but it's not recommended for AS because it's not it's not available for it. Doesn't work that well for it. So I had the fun choice of having to make the choice of staying on a biologic that was working for RA and just put up with the AS, or switch and try something else that could work for both, might work for one, might work for the other one, or might not work for either of them. And for me, the one we tried was Humira or adalimumab. And I am so great. I'm really grateful. I'm grateful for a lot of things, but I'm really grateful that it happened to work for both, because that was a real gamble. And so that's been helping me a lot for both conditions, and so far so good. It's holding out okay. And so my symptoms are well under control. So that's my story. Naomi and I actually both got involved in a support group, the Young Women's Arthritis Support Group. That's how we met. And so we actually really enjoy helping other people, and doing like the Dragon Claw crew do as well, is actually really advocate for other people like us as well.
That's a really hard one, actually. I think you do have to persevere and keep knocking doors. What you need to do is you need to find a rheumatologist yourself, like through places like, or anyone. You can get a referral from someone you know in the area, like a friend. Say, look, I see this amazing rheumatologist. You should go and see them. That's all you need. And then you take that name to your GP or any GP, and you just say, I want a referral to this rheumatologist.
And just tell them that exactly what we've been saying, that you don't have to have the markers for your condition, like the blood tests that I mentioned, but even just general inflammatory markers. Mine are normally pretty good. Even at the beginning, when I had a positive RA, or a positive anti-CCP, my actual inflammatory markers were fairly low. And so that on their own, they would have just said, oh, she's okay. But if all along my inflammatory markers have been very low in comparison to many people that I know. One of the things that Naomi and I sometimes do, and again, I'll be quick here, is that we get involved in training first-year medical students at Monash Uni. We do a presentation with them and a few other people, just to talk about the same sorts of things we talked about here, sharing our story. But one of the first things we tell them, and one of the things the lecturers pound into them, is the blood tests don't tell the whole story. Listen to the patient. The current update is they still don't know. But having said that, there is a very strong hereditary likelihood that if somebody in your family has an autoimmune condition, that they could pass that genetic predisposition onto you. Doesn't mean you're going to get it, and it doesn't mean it's going to be the same one. For example, you could have somebody in the house in the family tree with type 1 diabetes. Like I've got two forms. I've got a cousin's child with lupus. And so it can present, somebody else could have MS. I'm always watching my nieces and nephews because they could end up with a different form of autoimmune disease. So I try to promote the awareness there. So yeah, it's just the immune system can go crazy, but how it manifests is really dependent. But yeah, genetics is only one of them. So yeah, there's a genetic component for sure, but yeah, it doesn't mean you're going to get it. And or you could have the markers, but no trigger to set it off.